this point on, if you can just make sure you keep your hands exactly where they are. And just so you don't contaminate the area.
If one in the case like someone's itching, or the oxygen is itching, or the eyebrows itching, I'm going to be hanging right around here, so just say, hey, what do I need to?
And then, Mustafa, do you mind pulling it down a little bit?
Huh? Worked.
Yeah.
Do you need to scan this one?
No.
Third row down, maybe the one, and just allow the whole, I'm just going to flash real quick. I'll stand up and second row to the left. One more, I'm sorry.
Okay. Yeah, so we put our gloves on first. I'll send in this part where you
Yeah.
I know, I was laughing at that. Oh. The inside is cut? Yeah. It doesn't matter.
This ID is completely fogged off.
Thank you.
I'm going to disconnect all the way. I just need a little that first. I'm
Want me to
sorry.
connect this for you?
It's out. I already have it.
Okay.
Yeah.
It had to turn as she was coming in.
I know. Yes, I mean, that was how I did see it. That was how that, and then, we got it up real quick and. it's not gonna come.
You can pop in there.
You know,
Sorry.
in the
No, I opened it.
fourth door down, in the left corner, there's like some hemostats way in the back. Like some, are they just like laying there? They're just laying there on the left side in the back.
In the back.
Back. Like, like one of them should be like a clinic, like a force.
Yeah.
Yeah, just that.
Yes,
Perfect. It's all coming. Good for me right there. How about another flush? I'm gonna just flush from right here and see.
And is she on top of it? No.
No. Maybe we can just have him put one in at the ground here.
This is the highest this is up.
When I flush it, when I'm pushing like some fluid in, is that hurting at all, girl?
I was gonna try to raise it up a
Yeah,
little for you.
yeah.
Can I open it? Maybe that I don't know.
Yeah, I mean, it up inside, that's just like when
I
I
know,
bend,
yeah.
yeah.
I was gonna, because sometimes it's like round.
I have to squeeze the bag earlier to get it to start running, but I don't know if that's really the issue or not. Because even the back right now.
I wonder. I'm gonna just hold it up for you. should definitely have, she's in the right spot.
Like, I wouldn't want to get sedation for it if it's not working.
Right,
Yeah.
Thank you. Sometimes with these things like that, because she definitely had a
Yes,
some pain in her.
Yes, she did, yeah. I mean, for me, all the way, yeah, everything's open.
It's true. Slow.
Yeah, there's, I think like the third drawer down to the right. Is there IV supplies? It might be like in there. Like what?
Yes, thank you. Thank you.
Oh, is it one of those? They ordered those by mistake.
They're very cute. Is it different now? Very slow.
I don't feel comfortable. I just don't feel comfortable having that this is the idea I have for this procedure. I'll ask him for what I'm going, okay? Because I just, it's not running well enough to have.
I think.
Okay.
I don't know if she wants to blood pressure for our
I'm sorry?
I don't know if she
Put one in the bottom.
Gustavo, do you mind restarting it? Or you want to just disconnect
I'm
it?
just gonna drop this on the pen.
Okay. Did you want to disconnect it?
No, just not.
Retouch it, yeah. Just don't adjust it too much. Try to roll it in a little bit, yeah. Yeah.
I'm Tiffany. Another face has here, but I'll be with you in your procedure with that, okay? Any allergies to any medication? A few. Yeah, good. You want to know them or do you have them? I have them on your chart, just like to verify. And birthday is June 4th, 47. Sorry. Thank you. Could have been fun.
Here you go, Kathy. One second. Push that serum in that you set up. Let me know when you're ready. You can do it. Good. Thank you. Am I stuck on the cord? There we go. Thank you. You know what we can do actually? Oh, we already did it, it's okay. I have half of the
Oh,
contrast open.
you're welcome.
Can you copy, or Nina, if you can, there's a contrast bar in that computer right there. Can you twist all that top for me and then pour it in this bowl on the table? Right there, thank you. Thank you. And then we can fill in that until it gets dirty, you know what I mean?
Okay.
Your lines flush through, Kathy?
Uh-huh.
Just some pressure from my fingers here. I'm gonna adjust the sticky tape just a little bit, sorry.
So I like to feed it to about like 4 inches. Just out, and then I'll walk it toward me. So, because they always want to lead with the wire in the body. So then I'll put the torque on there. To where I know that much wire is out. And I'll lock it. Because when I give it to him, like, I'll push the wire out so he knows how much he's leading with. And then I'll pull it back so he can get it through the sheath. But then this way I know how much wire is out. And that wire is out leading the catheter. So I try to get that ready for them prior to them getting struck. It's easier for them. And then I just put it back in the case so it doesn't fly anymore.
Just like put off the bag and come in.
Okay.
As soon as, I don't know what happened to the LD, I couldn't get it to run. It was fine out there, I was out there. It's in the vein, I don't know if it's dislodged, or I don't know. He's gonna put one right beside where he goes through the case. He's gonna do an artery repair procedure, and then there's a femoral vein right beside. I'm gonna put that on right when he comes in.
Oh, okay. So this wire goes through the, what goes through to put these clothes in?
He's doing the access with the needle, and through the needle, and I take that there, it's into the right, the left thing, and then the wire goes, from there to, and follows whatever, and beads where they do it.
They just stay in.
They just stay.
And that stops the blood.
That will obstruct that artery, so then it can bleed
What's that?
through that to the heart.
No? Okay, can you grab our 600 micron needle and just leave it on this yarn? Yeah, or you can leave it right here. Thank you.
This one's a 3 meters.
Yeah, we won't use that. It'll just, yeah, we won't use that. And the last of these coils. So you can take those off. Yeah, I don't know. So you can take all of these top boxes off. And put them together. And then we should
Put
put
the roll
aside.
in.
Yeah, we won't use them. Just not in, just tell them already.
So when we don't get an IV active and running, I know she was saying this is the dilator we use. So we get access the same way with the micropuncture. So Yep, except for we go to the vein first. And then so we'll do the needle, wire, and then the sheath, and then we put this 035 wire in, and then this goes in. And then we pull the wire out, he hooks up the IV so the captain has access. And then we start all over again, just with arterial. Yeah, so, as long as the patients are relaxed and without it, we don't mind doing it. So I mean, it's only a little piece thing, just like nothing more than an IV out there, just in the leg. And we'll keep it in there until they need, in case they need fluids or medicine or anything like that. Yeah. This is the benzene, yes. So it's like, it's braided, so it doesn't have that hydrophilic coating, so it doesn't have to stay lubricant, like, it doesn't have to stay wet or anything. And it kind of like will hold shape a little bit more. So if you like were to bend it, it could keep the wire. Yeah, so. Where this one, the glide wire, it is like slippery, where this isn't. And it's harder, and this one will bend. Yeah, so it's a little bit stiffer. This is a little bit stiffer, where this one has a coating that makes it glide a little bit easier.
9, 10, 2 are being requested. 13 sisters. Check in 60 minutes or so, whatever. So then whatever time that was, I'll put there and then just like make some quick lines, because they'll take it from there and they'll do 3 cc's each. And then after the first one, it's every 15 minutes. And then it's 2.
So,
First check, we'll take 3 cc's. And then at 15 minutes, I'll take some more. In 15 minutes, I'll take some more.
this is Dr. Isaac.
Hey, how you doing?
Stop.
Nice to meet you.
And so, and then I usually use 2s and 3s. I usually use 3 by 7s, 5 by 7s. This is kind of flush, profile flush. You know, like once it comes out, it's out.
Yeah.
The twist that thing.
Yeah, good. Work it back. No, once it's in its place, you do that thing, play it, but you can't ever pull it back in, it's not
Once it's on.
retracted.
Yes, that's what we're just saying.
Just make sure. Alright, sounds good. You like it, right?
Now I feel like so
I just forget.
Relax.
no, not the hands on it.
He's got it.
All right, we'll do our timeout. This is Carol Elstein, birthday 6/4/1947. She's here for the hemorrhoid embolization. She is allergic to sulfa, macrobid, naproxen, and flexeril, and she has been holding Eliquis for the amount of days.
You got it. Thank you.
Uh-huh.
Hey, can I go okay? Alright, you look nice and relaxed. I'll tell you when we'll start.
Yeah, let me know.
And actually, it's down here tomorrow too. But if you want to see this, check this out. This is,
I was getting my thoughts on everything and stuff.
you know what? Here you go, tell us here. Yeah, I have some bias. Your bot?
What do you use?
Oh, no, I'll show you one. I'll show you one. I'll show you one that's exactly, we'll get a venous accident. Oh, Carol, just one pinch in the skin, okay? One quick pinch. This is the worst part of the whole thing, is just this one little piece thing. That's it. No, you must be remembered that for sure. You don't think?
I think if you stick it every time the confidence closest to the underlying bone.
That's generally what I'll do. But the irony is the one on the high,
Yeah.
was was one where ultrasound would have missed it. But, so what is what's your plan the rest of the day?
An apple, hopefully. No, we have a, you said which is 2 o'clock call here.
Yeah, and
So we'll get
Danny.
some lunch and 2 o'clock call. and
Yeah.
we'll head out to
Danny, did you see his email? For his setup?
5 o'clock rehearsal. That one.
He should be ready. He said he's gonna be set up in the afternoon, which he never is the case.
So the only issue I have is like 2 video files that I haven't been able to get into the box. So I gotta do that, so.
2 videos for.
The opening video and then the GE video.
He's doing it now.
It's crazy. For the sponsor talk.
Who's getting this
Me.
one? What day? Tomorrow or?
Sunday.
I mean, tomorrow. Kathy, you're all set. Go forward. Still on. There you go. Keep going. You're good. Let me know when you have a dose.
Okay.
Yeah. You want the fourth sit?
Give me
Tuesday.
It shouldn't be leaking, it might just come cool.
Top.
Any
Right?
couple of them.
Yeah.
Are they really soft?
Or when he was letting me, I
Like I
could
can push and
feel
push
it,
them?
it might be
They're
fine.
not super
I'm
soft.
just gonna use the
Some
solution
people
through
give me
it.
some.
You're gonna start to feel yourself, Kyle, get even more
I'm gonna tell you this, where should it?
relaxed.
2024.
Nothing is leaking.
It's just some saline, you know, you're gonna feel, oh, nothing's leaking here?
Yeah.
Yeah, if you feel wet fluid, that's just saline. That's normal.
You want to keep the box?
So I don't use the 2 week to deliver them because they want them wet all the time.
Thank you.
So,
You want another one?
yeah, they're both 3s, right?
Yeah.
Alright, so come out of here, right?
What are you gonna pull it out? And then you're gonna press it back.
Just take it out.
Yeah, you can push it forward, right?
Yeah,
Yeah, it's in a sheet. It's in
There's
a
the
plastic sheet.
Yes, I'll just flip this up, like to the end,
Okay.
and then I'll have you push from here.
Yeah.
But these don't need a twist.
This is break. It's like a break. It's attachment.
Oh, right there, you got it. Right there, the little twist.
And I'll give you like some sedation, a little bit of that and some more.
And then Mustafa, can we get a vial of 600 micron hydrochrome?
He's both the same size as that.
Yeah, there are 3 by 6. Should we use it? Oh,
I mean,
it's a video.
Yeah. Should I use this?
This one,
Alright, you know what, actually, hold on.
There in the, in the, supply room on the desk, there's a cardboard box. And then in that, there's 2 boxes of these. They're in a white box.
So would you
There's 3
want me to
vendors.
stay this end if we use the
Will
mics?
you grab them?
When you do the,
Is that where this, the microphone is?
it's on this, yeah.
Today's Friday. The answer is yes.
What'd you say?
You can't be seen.
That's okay. Thank you though.
So,
Joseph, can you, open this yourself for me?
A vial of that. Yep.
We're okay about the balance.
We're good.
you want that one too?
You want the bathroom or do you want us to?
You're gonna go all in?
Go all in. All right, there you go. Carol, one just quick pinch again, one quick pinch. That's it. Shouldn't feel anything else, okay? If you feel tired, take a little nap. You'll just hear us talking.
My favorite wire right here.
Ah, your favorite, huh?
Yeah, my favorite.
It is not better than the Asahi.
It's better for different things. Asahi's great. I love the Asahi. I like the body.
Boy, it's so floppy. Wait till you see how that's different. It was, who's your ultrasound? Everything. And on the handle, you can depth, gain, color.
Oh,
On the
you
hand.
can touch.
You don't even touch the screen. So, it's really good. All right, when do you want to start? We get the sheet, then we go with the bathroom.
Yeah, whenever you.
When I get the sheet, then we can.
Okay.
You can start asking.
I want to learn how to get a CTU up over every bifurcation because like half the bifurcations I can't seem to get over.
Yeah, that's why I said that.
But how to get over?
It's like steep bifurcation, you get a CTU over every time.
Not every, but 95.
95? Alright, that's something I gotta learn from you.
Last kid, well, when he sees, he'll laugh at us. Even he's probably seen the last one maybe a couple times.
Yeah.
It's exceptionally torturous. So here's one thing I'll do, Art, before we go to us talking about this case is, see how I'm just regular fluoro? I will take this regular fluoro and on this machine, oftentimes operate in roadmap.
Yeah.
So you'll see things like this. It's so nice,
Yeah.
you know, in terms of just being able to see your catheter, you know.
Yeah. So that's a sauce.
Yeah, we're doing hemorrhoid.
Yeah, okay.
We'll see too. I'm going to the IMA.
Okay. You always use sauce for that?
Yeah.
Yeah.
Do you?
Or
Or Nicholson or something?
yeah, something reverse or whatever we have reverse for.
All right, so we can start with just some, whatever you feel.
Alright, you ready?
I'm ready when you are.
So,
Welcome, Ari.
alright, thanks Dr. Bagla. So why don't you tell us a little bit about why we're doing this procedure today?
Sure. So, this is a young woman who actually has hemorrhoids, and you know, patients who either failed banding or they have not failed banding, but they have pretty significant symptoms where the GI physician may feel like they are not a good candidate for banding, like they might need multiple bands. Then we often get patients referred for hemorrhoid embolization. So she's undergoing a hemorrhoid embolization.
Very good. So the first target for hemorrhoid embolization are branches of the superior rectal artery. And therefore you have to get into the IMA to start.
You got it.
So what are some challenges about the IMA?
Okay. So one thing that's important is imaging your aortogram here like we just did and getting into the IMA. RAO projection.
RAO.
Yeah. RAO typically arises here, as you'll see it at L3, L4. Is really good imaging on her, but this might be just a little bit higher. You'll see hers arises at L2, L3.
Mm-hmm.
So we tend to use a reverse curve catheter, like a SAS, to get in.
Yep.
So once we get into there, then we'll go out of our RAO and we'll just go to an AP view, and you'll see here. We'll raise the table and get as much as we can on her. We won't be able to see now in this single view here all the way down to basically the rectum. We'll see the superior rectal arteries on this run, which you'll see popping up right here in a second. Let's see these.
Bifurcation of the superior rectal.
Yep, so we'll see that bifurcation here, as you can see, of the superior rectal branches. There's two main in her, two main left and right superior rectal, but oftentimes there's four most commonly, so anterior and posterior, right and left.
Yep.
But the only reason we have this image is really to get our microcatheter down to above that bifurcation, and then we'll do our...
So you use this as a roadmap.
Yep.
To get down.
This
and
will
then
serve as
you
a
do
roadmap.
selectives of each of those.
You got it.
Yeah.
So we're going to work our microcatheter down. We're just getting that set up right
True
now.
select, huh?
A true select.
2.0 French?
2.0. So Nice, smooth hydrophilic catheter. You've had a lot of experience with this. Why don't you tell me about your experience with this catheter
it's a
too?
well-built catheter. It works really well.
It does.
One of the unique things about TrueSelect is that it comes in the 175 cm size. Now you don't need that for this case because this is a groin access for hemorrhoid embolization, but that is a unique characteristic of TrueSelect.
Yeah, I mean, I like that. That advantage, of course, in these individuals that you're going radial on are really important. I tend to not go radial very often for hemorrhoid embolization.
Yeah, why not? Explain that.
Yeah, it's interesting actually you say that. There are sometimes, just like in those distal PAE cases where you need to get really down distal internal pedal,
Yep.
for example. Pull that wire back 2 nipchins. We have to go here very distal too, right? So when we get down to our rectal branches, we're going below the level of really oftentimes the pubic symphysis.
Yeah.
So when we go that distal, even in individuals who are shorter, it can be challenging. Now the 175, of course, will overcome that challenge.
So I guess one advantage perhaps radially is the angle at which the IMA arises.
Yes.
Maybe a little bit more favorable from approaching from a proximal aorta.
Absolutely. So I'd say coming from radial, what's nice about that is you can bring your MPA down beyond that left colic branch. And so you can get very good imaging, 5 French imaging distally or 4 French. And then when you get that imaging, of course, we'll talk about really the contribution of middle rectal arteries. And so that can be really advantageous.
So at this point, you're not looking at any of that quite yet because you're just using this to get down into those arteries. And then you're going to shoot them more selective and look for anastomoses and of that sort.
You got it. You can see our fathom wire is down ahead of our TrueSelect. And we'll just bring that back here out of this branch. Nice about this catheter too is even in these branches here, it's oftentimes very delicate and easy just to advance that catheter by itself without a wire.
Yeah,
so
absolutely.
That can be really nice.
Sure is.
So your experience with sort of 2.0 catheters and this wire, tell us a little bit about this wire and why you like this one.
Yeah, Fathom tends to be my first choice of wires. Reason being is because of the shapeability of the tip and the ability to reshape it. So you can give it a custom shape, and if the situation changes or you're headed into a different branch that needs a different shape on the tip of the wire, you can reshape it.
Right.
I appreciate that a lot. And then it's just, it's an 014, it's nice, it selects a lot of branches. Now sometimes that's annoying because you're selecting every little branch as you're going, but other times that's what you need to get into where you're going.
Absolutely. Well, it's interesting, in this particular case here, as you can see, so we've now done our angio here at that bifurcation of right and left superior rectal. The dominant supply to her hemorrhoidal cushion here, as you can see on the left, right? So that left branch that's going below the level or at the level of the pubic symphysis. It does have a little inflow to it, which makes me suspicious there could be a little bit of middle rectal inflow, albeit we don't see any retrograde filling of a middle rectal branch. So we'll definitely want to target that artery, but as a female, she typically has these smaller size arteries that we identify, right? I just happened to take the right because it went to the right first. And then we're going to use the wire and go further distally down that right superior rectal artery.
So on your previous angiogram, you commented how we were only seeing 2 branches of there's usually 4 branches.
Exactly.
So do you think in this image that proximal branch is actually the other two branches? It looks like they may be extending downward towards them. That proximal branching point.
Absolutely. Yeah. So once you're right, 4 centimeters down each of those main right and left trunks, then there are branches that go right down the middle that are probably posterior branches as well. And so what we'll do here is we'd want to get down the larger of these.
So based on this image, your plan is to go down to both the right and the left that are headed down distally.
You got it.
Even though the left is probably what is really supplying the hemorrhoids.
Left is probably the more dominant, but if we don't take care of both of these, then her recurrence rate would be very high. So first thing I'm doing here is just going around distally here. With it, 2 French is really advantageous in someone like her because her vessels are actually natively small. These are fairly small arteries. So once we get to this position, if we're identifying the cushion well, the hemorrhoidal cushion, which hopefully we'll be able to see on this run here, you can see that branch going down.
Way down there to the pubic symphysis.
You'll see a little blush here. So you'll see the blush of the rectal mucosa, but then all the way down by the pubic symphysis, you'll see us actually filling the hemorrhoidal cushion. So at this point, question becomes, do we go further down here, right? Or
Yeah.
do we deliver our therapy from here?
And there's your reflex, right, into the middle rectal.
Into the
on
middle
that right
rectum.
side.
You got it. So via filling either branches of like typically either internal pudendal or obturator branches. So
Yep.
what we'll do here is sometimes we'll make an attempt to go around this bend
Mm-hmm.
and go a little bit further distal. We can see.
Distal to the anastomosis.
Exactly. Well, not even so much. If we can go distally, anastomosis is great. There, on this case, you can see there's just so many small, channels to get past. But if we can, it might be nice to get beyond that first loop into the vertical segment of that artery.
Right.
So, we call that
Maybe
the
a
corpus
test for the
cavernosum
fathom here.
rectum. Corpus cavernosum rectum. You're really
Yeah,
calling out a challenge in this wire, huh?
challenge to the fathom. So that's a different cavernosum than what you and I are usually dealing with.
Yes, exactly. That's a completely different cavernosum. So we'll see how this wire does. I'm pretty confident that torque device moves.
Usually a little twirling with the wire will get it through things.
Yeah, well, actually. We'll see, all right.
Yeah.
And it could, and honestly, for this, we're just looking to see it's going on a small branch. It may not be a reflection of the wire as much as it is just a reflection of anatomy here, I think. But
So there's I guess one of the papers talks about if you see the anastomosis like this, you just particle embolize until the anastomosis is no longer visible, which is a little bit of an interesting technique, but that's what the most recent paper in JVIR, that's what they described.
yeah, I mean, I tend to use both, as you know, particles and coils. So with that, technique, I would say we are oftentimes able to get distal embolization there at that cushion, because that's what we're looking for, right? My fear of just using particles, of course, is then the amount of particles you need to achieve stasis. And in the most recent randomized control study or comparative study that looked at different size embolics, it looks like no matter what, it's still favoring going towards that mucosal vessel. So.
And what happens here if you just push the catheter? Will it go on its own?
Yeah, so you can try that here and see. I think that it looks like no matter what, it still wants to go
same-
that medial,
Still
that
selects
medial
that, yeah.
mucosal branch.
Alright.
And rather than honestly have spasm and
right.
and go for something that can be more distal here, I'd say we
So you're gonna
park
coil
here.
Yeah.
I'll take a 2 millimeter coil. If we can.
Gotcha. 2.4 or 2.6?
2 by 6 should be good. First thing we're going to start here is while we're getting that coil ready, we're going to start with our particulate embolic.
Yeah, so what are we using for embolic today?
So we're using bead block today, and we're only going to really deliver just such a small amount. And the reason why we use a small amount is we just fill really the hub and then a little bit of the catheter.
So you're not even pushing through all the dead space, you're just putting like a 0.1 or 0.2 cc's of
Absolutely, yep. Just filling that hub, and, like you mentioned, 0.1, 0.2, and then delivering an antigrade. In here, we're using 300 to 500 size. Typically, we'll use even a size a little bit larger.
5 to 7.
5 to 7.
600 somewhere.
Yep, somewhere around 600 seems to be an ideal size. Our challenge in her actually is that the reason the size works out well is because the size of her
Smaller vessels.
smaller vessel. So it's really not a one size fits all. So after we've got that through,
Personalized medicine. Personalized medicine.
there you go. So
All right. Ready to
Now.
drop the coil here.
ready to go through our coils here. So you can push that in.
So which coil did you select?
Yeah, so we're using the Boston Scientific interlock coils. This is a 2 millimeter coil by 6 cm in length. And so it's nice here. We'll be able to deliver this coil here right in there, and we'll hold some forward pressure on it. So obviously that coil doesn't come back on us. And let's see here. You can take comes in, as you know, in a casing, right? And then once this coil comes out, it's not retrievable.
It's detachable but not retractable.
You got it. You got it. So here with that pushability, what's nice is despite that acute turn at the IMA, it's still able to keep its shape there.
There it goes, look at that.
And it looks like even the coil wants to take that preferential turn preferential turn down towards what our branch we wanted. What's happening is nice now is as bringing it back, it's backing really well.
It's nice and soft. Right?
Nice and soft. So you can see the retractor. I'll just move it back and forth. You can see that little dark spot is the retraction portion of the coil. It's coming back, and that's going to come
I
out.
have to say the
We'll
magic
take
words.
one more maybe. Who's a 3 here? We'll back this up with a 3. What are those magic words?
Peter Pattison. I don't know.
Peter Pattison. Peter Pattison. That was nice. That was nice. I like that. Sorry, what are your thoughts really wholly on, let's talk about sort of hemorrhoid embolization in the space?
Yeah, so it is I think it's just exciting that there's another option that's available for patients that doesn't involve a surgery. It doesn't involve banding, which although it sounds pretty benign, pushing a band around vessels in the rectal region is not as benign as it sounds. So just to have another option available that's minimally invasive with very little discomfort associated with it I think is really exciting for patients.
Yeah, it's really nice. I will tell you, patients who've undergone previous banding who undergo something like this, they always remark on how easy this is to go through compared to, honestly compared to what they went through with the banding. And so that's been something that has been really nice to hear them say. So we deployed a 2 millimeter, then a 3 millimeter. You can see despite being in probably a 1.5 millimeter vessel,
Right.
it was able to coil well. Following this, we typically will do a run, make sure that vessel's occluded, as you can see here, yep.
Yeah.
And then I'll check to see if there's anything else really supplying that. And on the right side, none of those, on the right side, you'll see there aren't any other branches that are going down. It's nice. And then on the left side, which we'll look at next, you'll see here, we'll go over to the left. And,
So what are you thinking about that anastomosis at this point? Are you going to leave it as is? Are you going to go take a look at it?
Yeah, so it's a really good question. So at this point, I probably will not take a look at that anastomosis. In order for us to really go treat a middle rectal in the same session of treating from the superior rectal, we'd have to see it as a really prominent inflow vessel. And we'd want to see it really perfuse an area of tissue of the hemorrhoidal cushion that we couldn't get to from here, either with our beads, because meaningfully, right, these patients will get a significant, back again. So, meaningfully, we'd like to see them, honestly, have some change in symptom with respect to like a failure of therapy.
Before you go back. Yeah.
Before we go back.
Yeah.
That's how easily we got distally there with that.
Now, what about coiling? So when you coil, is it standard? Usually use 2 coils in a vessel. Is that kind of
Typically, I'll use 2.
standard?
Yeah, I mean, as you know, patients of the interventional radiologist, if we waited a minute, we probably would have gotten some.
But it's impossible for us to wait because that's the nature of our specialty.
Exactly. So what do you think of this one? It's
Well,
a
now
nice.
you're really seeing a good anastomosis there.
Exactly.
That actually looks like an inferior rectal.
Yeah.
That's
So that looks really nice, and I think we're distal enough here. Again, if we get beads in here,
Yeah.
we should be
Shut that down.
we should be able to shut that down pretty nicely. So I'll go back and grab our beads. Tiffany, I'll take our clean syringes over there and we'll get our beads right here. And like I mentioned earlier, we're just really getting a little bit in here. Flush these through, and after we get these through,
It's interesting from a place where we've done a lot of prostates. We always see these branches, the middle rectal, the inferior rectal, all the time on our runs, and we kind of just think very little of them. Because it's prostate, you don't care about it unless it's in your way and it's going to be an anastomosis. But now these are big players in the hemorrhoid
yeah,
world.
you're exactly right. I mean, it's funny. These small little channels, right? 2x4 sheet. So we're going to use a 2x4 coil. It's going to be very similar. I'll probably actually use a 2, and then I probably will use another 2 because this is a very small branch. And we could here try little patients, give it 2 millimeters and see.
You want to try one and we can talk for a little while?
Yeah, exactly. Absolutely. But so back to all of these branches and getting into these. I will tell you, in just a case last week, similarly with a 2.0 catheter, there are a lot of narrow, channels here. I think we could get beyond anastomosis like this with a 2.0 catheter, we have gone from superior rectal to middle rectal branches via the IMA. So I am confident that this catheter could do that if need be. If you do notice one thing here on the field R, you'll notice that one thing you find interesting is, despite having this catheter, because of the amount of dead space I have eating up my base catheter, I don't really have a lot of microcatheter left. So
what length? That's basically based on the length of your sauce. Right?
exactly. So this is an 80 cm catheter base. So with that 80 cm, but now I'm returning another, if you will, at least 40 cm going down towards this branch.
Right, and this is a 130 True Select.
Yeah, and so exactly. So a 155 would easily be, I'd say, a comfortable length to use. I will, we'll pull this catheter back here a touch. I'd say let's go for one more. Coil. So that's about how long. That's about how long I'm kidding.
All right.
So let's do this. Let's take a picture, anyways, and then let's do the no weight IR weight.
Yeah.
Do the no weight
The
IR
compress
weight.
is going to blow through
And then
it.
let's blow right through it.
It's
So
going
that
to blow
one's-
right through it.
Oh, look at that. Look at that. All
Oh,
right.
it's including?
The two of us have already eaten our words.
Well, it must be just the interlock coils.
Yeah, look at that.
Yeah.
Fibers. Actually, it does speak to a really nice thing, I'd say. I will take one more, just for more long-term inclusion, of course. But I will say that fibers on coils. Why don't you give me your thoughts on coils with and coils without?
I prefer fibers.
Yeah.
Coils are not, for the most part, not mechanically occluding.
Yeah.
They're creating thrombus that's going to occlude. Although there are some technologies out there that are trying other things, but my greatest experience is with fiber coils, and that's my bread and butter.
Yeah, I agree. And preference of why I tend to use these over the soft coils is because these have that fiber, and I mean, this is a good example. Both of us thought we'd blow right through here.
Yeah.
But obviously we did. It's nice. So we'll go in here with one more coil. Actually, this is a soft. So let me see what you got over here.
Let's see, you want a
2-4 and black.
2-4? Yeah.
So just as we're talking about fiber and no fiber.
There was no fiber.
No fiber. Yeah, let's go with the
You
one
know
with
what happens
fiber.
when you don't have any fiber in your diet? You get hemorrhoid.
I think you just came out with the next, next coil commercial.
Well, so Boston, they're going to have a whole new line of coils that are hitting the market soon, so they're going to need some slogans.
There you go. So following this, right, so let's go back and review our previous set imaging here. We were right at the bifurcation. When we're looking at this, it looks like we've gotten the dominant two vessels that are supplying us. Are there some other small branches? This comes up all the time. Should you try and chase down these other tiny branches that are more in the central portion of the rectum, if you will, not on the lateral walls? If they were larger than this, or there was flow down to the cushion, absolutely. But in someone like her, it's not. You're more likely to cause harm and perforations to be going after those things than you are otherwise. In some other cases where the arteries are much larger, absolutely. I think I'm going to put this on roadmap so you can see this. Just the coil roadmap itself as this comes out, and see how nicely that'll coil easily. Get that little push there.
There you go. Nice.
Yep. Okay.
Okay.
And
So,
then
technical question for you. If you had the normal anatomy, or the most typical anatomy that you see, where there are anterior and posterior arteries on both the right and the left, do you use an oblique to catheterize those? Because they tend to overlay on top of each other in the view?
I tend to, I would say personally, I'll prefer to do everything in this projection if I can. When you do everything in this projection, of course, it allows you to not have to move the C-arm so many times.
Yeah.
So that's nice. That's our completion run here. You can see we have great, if you will, diminished vascularization here towards the rectum. But I tend to work in this projection. It's fairly obvious to see. Now, if I'm on one side and it's my last vessel, of course, then I'll go to an oblique projection and look for something else. But you can see here, this is what we'll typically do. In a case like this, without a large middle rectal inflow, we won't typically examine or look at the internals.
Right.
I'm taking out that True Select, so say goodbye to it, all right.
So we're at the point of the case where you're taking out the catheter.
Yep.
You're going to close up the artery.
Yep.
This has been, the case has what, taken us about 35 minutes or so, 40 minutes? something
About
like that?
35 minutes, yeah, 40, yep.
So just to point out what how simple these cases can be, once you get used to them.
Yeah.
So to come in as a patient and to have a case like this where all you're doing is get a single puncture in your groin area, and all you're feeling really is the lidocaine shot.
Yep.
And then to have your hemorrhoids treated 40 minutes later without feeling the pain during the procedure.
No bowel
Pretty
pressure.
remarkable.
Yeah, it's really unbelievable. So I think this procedure has really come a long way, and I think offering it with really such high success rates, as you know, published, now over 90% consistently, compared with other therapies like banding with success rates that are probably 20% lower, or may require multiple treatments. It definitely has become very desirable for our patients.
And it'd be interesting if there was a study that did a kind of a quality of life survey and compared banding to hemorrhoid or hemorrhoid embolization.
Absolutely.
How that would turn out.
Absolutely. Lori, thanks for joining today. We'll close up here and look forward to seeing you again.
Yes, perhaps later on today.
All right. That was good. That was it. Can you hit that button on the top left of there?
Would you like the light on?
Yes, please. Thank you. Carol, just feel a little pressure, okay? Kathy, you can pull that out for me. Let's show the Minx guy how real close your voice works.
Is that what you use?
Who knows how often that thing pops? This is real. I mean, you've seen this, obviously, right? Or no?
Yeah, a
Just
while
watch it.
when I
It's
was
so
when I
easy.
was a fellow.
So monorail, you'll love it. It's like, so turns it in, okay, just like everything else, right?
Wait till you get
In,
blood stirring.
foot plate, up against the wall, okay, so negative pressure. I stabilize here. You may feel one pinch, Carol, stitch, okay? Pull out the stitch. There's a cutter right here on the front. Drop the foot plate. No, just pull out, and then there are my 2 stitches, okay? Over the wire, so if anything fails, you can always go back. So, I mean, I will tell you, like,
So you're putting it through with the sheath?
no, it has a side hole.
Oh, okay.
Yeah. Actually, it's the same hole the wire came out when it
Yeah,
went in.
so that's what the wire goes in, and then
That's
you
it.
pull the
So that's, yeah, so
device
that's
out and then
2
you tie it
strings,
down.
right? Yeah. So the knot now, back actually when you saw it,
Yeah.
because it was probably when I used to do them a lot, we had to tie the knot.
Yeah.
Now, the knot's tied.
Oh.
And it's down there.
Just cinch it?
Yeah, so there's a white portion for like whitey-tighty for tightening, so don't pull that one. I take this 3 coils.
Yeah.
This is a pusher. It's a monorail pusher. So I take the string, I hold a rail, and a sheet pin and pulls that out. I push the knot down. The knot gets pushed down, and it is cinched on the wire. I mean, and if you want to double, triple check, this is why, like, if they're out there and you watch, right? Pull the wire. It's so tight on this wire.
Yeah.
So now she'll pull. When she pulls, I just keep tightening it down a little more. I'm obviously not gonna, I don't wanna like pull too tight down the wire
Yeah.
to rip it. That's it. Then I take both together,
Uh-huh.
and this is the lock step. All you do is you put that back on,
Yeah.
push it down, it's locked. And I'm just pushing really light, but this is the tension. I push here, that cuts into the skin. I go for like 4 or 5 minutes.
Yeah.
And I can, this is the one key. You know what you know.
Yeah.
So the big function, so what I can do is when I'm pushing that back, you don't have to puncture through the fat. It's like you'll go like this, like the fat will crunch.
Yeah.
So when I push down, I'll have them on the left hold pressure, and it literally straightens out the fat, and the pusher will go all the way up. And they really get it like this. And oftentimes they'll be like, this person, but anyway, never popped. And I mean 16 French rolls, 2 devices, never popped. So I mean, you do have both, but if you
Well done. Just putting some pressure with my fingers here, okay?
Oh, yeah,
You agree?
take a walk.
Yeah.
Happy 20 cc's, maybe? Thank you. It's interesting when you hit the button and it's still going.
Yeah.
So This is no signal. Because we're on. Oh, no, it's not. Now.